Hello, my name's Kevin Fernando. I'm a GP partner at North Berwick Health Centre near Edinburgh and also Education Director of GPnotebook Education. Welcome to the current season of GP Notebook Podcast, a bite-sized regular chat for all of us working in primary care. Podcast will cover clinical tips and hacks, as well as hot topics to help make our lives a wee bit easier, but ultimately to help improve the lives of our patients in primary care. I've been recently involved in planning a series of webcasts for healthcare professionals in the UK, which are all taking place during May 2021 as part of what we're calling Chronic Conditions Month. The webcasts, which are being run in association with GP Notebook, are designed to help all of us working in primary care with the significant challenges we've faced in diagnosing and managing chronic conditions over the past year in the midst of the COVID pandemic. Healthcare professionals in UK can register to attend all the events for free at www.chronicconditions.co.uk. So I hope you'll be interested in joining us. And to accompany these webcasts, the Chronic Conditions faculty has recorded a series of podcasts in the past few weeks in which we provide some practical advice and suggestions to help you optimize care here and now across a range of conditions. So, without further delay, please enjoy the third in this series of special episodes. This one features myself and Dr. Peter Bagshaw. I'm delighted to be joined today by Peter Bagshaw, a GP in Somerset, CCG lead for mental health, and also co-author of an older person's mental health primer. So welcome, ladies and gentlemen, to our new podcast, which comes to you as an introduction to Chronic Conditions Month 2021, to be held throughout May. This will include a whole string of interactive and informative webcasts designed to address the primary care challenges of diagnosing and managing chronic conditions at a time when COVID-19 has thrown out the rulebook. So today, in this podcast, we're going to be discussing severe mental illness and diabetes. So thanks, Peter, once again for joining us.
No, thanks, Kevin. It's great to be having this discussion. And I think the fact that we've got this huge overlap with chronic conditions makes it really interesting. So I, as a GP, have always hated diabetes. I find it very complex and very difficult to understand. But the link with SMI and with other chronic conditions, including dementia, has raised my interest in diabetes.
Absolutely. I think I'm very much looking forward to this discussion. But I thought perhaps, Peter, we could start from basics, really. Severe mental illness, SMI. What do we exactly mean by SMI?
It's not narrowly defined, but in general, we mean severe depression, especially bipolar depression and schizophrenia. And both of those have particular issues around diabetes and other cardiometabolic conditions, which sadly accounts for the roughly 20-year premature mortality in this group.
So, thanks for that, Peter. And of course, chronic diseases such as diabetes plays a huge demand, don't they, from both a lifestyle perspective and treatments for people living with diabetes. And of course, my patients worry about the potentially debilitating complications and the reduced life expectancy that can be associated with a diagnosis of diabetes. So depression, severe depression, can sometimes therefore be an understandable response, can't it, to a diagnosis of diabetes?
Absolutely. It's fascinating, isn't it, the way the links go both ways. So if you have severe mental illness, you're much more likely to have diabetes. If you have diabetes, I've read figures saying that you're about 3 times more likely to have depression, which, as you say, is completely understandable. And also, you're much more likely to have poorly controlled diabetes if you have severe mental illness. And again, you'll know a lot more about this than me, Kevin.
Yeah. Oh, it's a really fascinating area and very important area, as you rightly pointed out already as well. I mean, the biological factors associated with diabetes, the hyperglycemia or the hypoglycemia, themselves have a negative impact on mood. And a previous meta-analysis, albeit an older one, did describe an association between the severity of depression and actually HbA1c control as well. So very much it's a bidirectional relationship, isn't it, Peter, as you've already eloquently explained, between severe mental illness and diabetes. And then you alluded to some of these, really worrying statistics as well about how common, how prevalent mental illness is in people living with diabetes. Depression and anxiety is twice as common in those living with type 1 and type 2 diabetes compared to the general population. And depression itself, as we discussed in type 2 diabetes, is associated with poor metabolic control. But I suppose what really struck me is that among those people living with type 2 diabetes, major depression is associated with an increased risk of clinically significant microvascular and microvascular disease, and also an increased risk of mortality. So actually, that combination of depression and diabetes has an impact both on quality and quantity of life, which of course is very worrying from our perspective as an HCP, and of course for my patients living with diabetes.
It's a real vicious circle, isn't it? So people who are depressed are less likely to be active, so they're more likely to put on weight. People with schizophrenia, there's been some fascinating recent evidence that there's even a small genetic link, that if you're more prone to schizophrenia, you seem to be genetically slightly more prone to diabetes as well. And then, of course, if you have serious mental illness and schizophrenia, you're likely to be put on an antipsychotic. And unfortunately, all the antipsychotics, even the newer atypicals, are much more likely to cause weight gain, which are more likely to trigger or worsen type 2 diabetes.
Absolutely. That whilst that link is very fascinating and very important, we there's still so much we don't know, don't we, about that link? I mean, you mentioned the medications are very important, that we're aware of that, and I know we're going to discuss that shortly. But there's emerging evidence too, isn't there, that the chronic stress we see in depression, in schizophrenia, leads to high levels of hormones such as cortisol and other inflammatory cytokines, which leads to activation of the hypothalamic pituitary axis and a higher risk of diabetes. It really is a fascinating area of research, isn't it?
It is. And if people attend our May conference, I've got some fascinating slides, which sadly I would struggle to remember the details of, that show all this interlinking going around. So it is fascinating. And of course, throw into the mix things like diet, which again, the gut-brain axis is recently being increasingly recognized as being important, which again can cause inflammation that seems to worsen mental health issues. So it's a really fascinating and, as you say, developing field. So I guess the question for us as GPs is, what can we do to break this vicious cycle?
Absolutely. That is the $64,000 question, isn't it? So you mentioned medications, Peter. Of course, you have a lot of experience in medications pharmacology for severe mental illness. Any sort of top tips, pitfalls to avoid as well when choosing those medications when we're treating depression or more severe depression or schizophrenia, particularly in people with diabetes or at risk of diabetes?
Well, sadly, it would be lovely to be able to give a list of drugs saying these are the ones that you should choose that won't cause weight gain and increase your risk. But all the antipsychotics seem to give that increased risk. So my top tip would actually be to try and keep the use of medication to a minimum in this condition, because unfortunately there doesn't seem to be a safe drug that we can use. There are particular ones, aren't they, that have higher risks. And in particular, I'm thinking about the ones that have a high anticholinergic burden. So the older antipsychotics have a lot more Parkinsonian side effects, for instance, so they tend to be avoided. Likewise, the older antidepressants have a lot more cardiac problems. But in general, I think we would say all of the antipsychotics are really bad news. And so you need to be on the lookout for early signs of weight gain. And I don't know what you think, Kevin, about the role of lifestyle, low-carb diets, that sort of thing, in terms of trying to control this. There is some evidence, isn't there, that people look for that sugar hit if they've got serious mental illness, which exacerbates the insulin resistance. that leads on to metabolic syndrome.
Yeah. Oh, absolutely. There is emerging evidence to suggest that, but also good quality evidence, isn't there, that people with severe mental illness, such as schizophrenia, are motivated to change their lifestyle, stop smoking, for example, and lose weight. It's a myth, isn't it, that people with severe mental illness are not motivated to change their lifestyle. I know that we know that from our collective clinical experience. So absolutely, like we would do with any patient with adverse cardiometabolic risk factors, we must reinforce that all-important lifestyle advice. And whether we take a low-carb approach or a different dietary approach is very much down to a discussion, isn't it, between us and that person sat in front of us about what's realistic for their lifestyle. So absolutely, we should be, as with any patient, reinforcing that all-important lifestyle advice.
I'm really glad you raised the question of motivation, Kevin, because certainly until I started looking at the evidence, I think my feeling was, well, these people have got so much else going on in their life, they're not really going to be motivated to change. And as you say, the evidence is quite clear that that's not the case.
Absolutely.
So we should be absolutely as focused in helping our patients with schizophrenia and other severe mental illness to improve their cardiometabolic rate by improved lifestyle. So that's a really great myth-busting thing that you brought in, and something I hope everybody takes away from this.
Absolutely.
What would your next step be? We've gone down the lifestyle route. Maybe it's not been successful. Are you an early intervener in terms of medication?
Yeah. So another fascinating area as well, isn't it? I want to, I suppose relevant to this, your question there is, I was delighted to see that severe mental illness and the use of antipsychotic medication are now both risk factors in the updated Q-Risk-3 calculator and also the Q-Diabetes calculator, assess 10-year risks of diabetes. Very important, isn't it, Peter, that these are identified as major risk factors for future cardiometabolic illness.
Yes, absolutely. And the issue of fat shaming is a difficult one, isn't it? So I think we need to look very early for increased weight gain and intervene on that. And the way I try and approach it is say, I'm not trying to talk about fat shaming or discussing your weight. Obesity is a side effect of insulin resistance and metabolic syndrome. And so it's a warning flag that we need to be worried about your cardiometabolic health and intervene in that. Does that seem a reasonable approach to you, Kevin?
Yeah, absolutely. Going back to that question you originally asked me, I am an early intervener with metformin alongside any antipsychotic therapy. So if I'm going to commit, or my local psychiatrist has committed my patient to a long-term medication with, say, something like olanzapine, we start metformin at the onset to help, as you said, mitigate some of that weight gain. I mean, I know metformin is essentially weight neutral, isn't it? But you can tend to weight loss. But more importantly, as you said, just to help mitigate some of that insulin resistance associated with some of these antipsychotic drugs. And I've had some really hugely beneficial effects in terms of mitigating that early weight gain that you've alluded to. So certainly it's something I think we should all consider in primary care, perhaps after discussion with our local psychiatry colleagues. And then, of course, that has a knock-on impact, doesn't it, on overall cardiometabolic risk reduction as well.
I'd agree. I think there is a case, isn't there, for co-prescribing it with antipsychotics because we know there's such a high risk. And what do you feel about statins, where, again, some people make the case that almost by definition, if you're on an antipsychotic, you should be on a statin?
I completely agree with this as well. We should have lower thresholds for considering statins for primary prevention. Of course, we're talking about here for cardiovascular disease in anyone living with severe mental illness. The nice lipid 2014 guidance, a wee bit out of date, ripe for an update, did suggest a 10-year, 10% threshold for considering statins. We might even want to consider a lower threshold, or as you said, even just co-prescribing it alongside long-standing, long-term antipsychotic therapy. So a really useful tool, Peter, I don't know if you've come across it, it's an RCGP-supported tool called the Leicester Positive Cardiometabolic Health Resource. And it's essentially a primary care nurse-led toolkit which facilitates a simple assessment and intervention framework to protect the cardiovascular and metabolic health of our patients with severe mental illness, receiving, antipsychotic medication. So it encourages us to check a number of parameters: lipids, HbA1c, blood pressure, weight, as we've mentioned a number of times, and encouraging us not just to screen for these parameters, but to intervene with things like antihypertensives, metformin, and statins, as you've asked me as well. So yes, again, to answer your question, I would essentially co-prescribe statins for my patients with severe mental illness who I know are going to continue on antipsychotic drugs long term.
I think that's really interesting, and I completely see the logic for that. I would very much focus. I'm into lifestyle, and I'm sure you've seen the work that David Unwin has done in reversing type 2 diabetes in over half his patients. So I would be very keen to look at those lifestyle factors because I don't know if you agree, but I've read figures suggesting that, for instance, hypertension, idiopathic hypertension, essential hypertension is probably 85% due to metabolic syndrome. So again, reversing that, we can help our patients with high blood pressure. Do you agree with those figures or not, Kevin?
Yeah. Oh, the figures, I've got to admit, I'm not specifically familiar with, but absolutely, just from my own clinical experience, I would suggest that sort of magnitude of the contributory effect is quite correct. And we, again, hypertension is a great example you brought up. So many things our patients can do from a lifestyle perspective to reduce their blood pressure. There's a number of lifestyle interventions that are as good as, if not better, than many of the drugs we use for hypertension, isn't it, Peter?
Yeah, absolutely. And they'll often improve dyslipidemias as well, won't they?
So absolutely. So, once again, completely agree with you. We cannot underestimate the benefits of lifestyle intervention for all of our patients, but particularly for our patients living with severe mental illness as well. So I thought, Peter, taking a step back from things, we've been, of course, focusing on diabetes, our patients living with diabetes. But we really should be vigilant and alert to the symptoms and signs of depression in anybody living with any long-term condition, shouldn't we?
Yes, and our nurse-led diabetes clinics will generally say, have you got impotence? Are your toes dropping off? And at the end of that, have you got depression? And by the time you've gone through the checklist, I think a lot of people will say yes, won't they? But diabetes, particularly depression, particularly in older people, often doesn't present with people saying, I feel depressed. So I've taken a particular interest in older people's mental health, and they will tend to present in a different way, a bit like children, in a non-specific way, often with behavior changes, losing interest in things. But again, we'll often say, well, it's understandable maybe that you've lost interest in stuff because you are older, frail, in a nursing home. So there's an estimate that we underdiagnose dementia and depression in nursing homes by about a factor of 5. So proactive screening for depression in particular, for older, frail people, is really important.
And would you suggest to me, to our listeners today, any specific screening tools, or is it just all about having a conversation with that person or a loved one? Any tips for us there, Peter?
Yes, there is a geriatric depression score which you can use, and it's in the mental health primer in the appendix. I find the 2 questions, 1, do you feel depressed? And 2, have you lost interest in things? Is absolutely as useful as that. And it's that anhedonia, that's loss of interest. And I'd cite Alistair Burns' grandparent test, that if somebody has stopped enjoying seeing their grandchildren, it's likely that they have very severe depression.
Okay. That's a really useful practical take-home tip. I mean, those are, of course, were the two questions. Well, we've not had QOF in Scotland for a number of years now, but those were the two questions we used to screen for depression in any chronic disease, courtesy of QOF, wasn't it? During the past month, have you been bothered by having little interest or pleasure in doing things? During the past month, have you been bothered by feeling down, depressed, or hopeless? So essentially you're saying continue that even for our older populations as well.
Very much so. And don't be put off when they say, well, I haven't really got anything to be interested in, or you'd expect to feel down at my age because I've got all these illnesses or whatever. So don't be deflected if they give a positive answer to your screening, but then give reasons why it should be positive. And it can often present in a very similar way to dementia. The two can be very difficult to diagnose because dementia often presents, about 80% of people with early dementia present with apathy. And people with depression also get a slowing down and memory issues that you can get with dementia. So it's sometimes worth a 6-week trial of an antidepressant if you're not sure which it is. That's perfectly valid.
Great, no, thanks. That's a really, really useful practical tip there again. So perhaps then returning to one of my patients with diabetes that we've diagnosed with depression, do you mind just giving us a few tips and again, pitfalls to avoid about both psychological interventions, but also pharmacological interventions we might consider as well? So maybe starting with psychological interventions, Peter, any top tips or pitfalls to avoid for me in primary care?
I think a top tip, again, going back to older people's mental health, is that we refer very few people for talking therapies in older age groups. And actually, the evidence is that they stick with the talking therapies and they have better outcomes than younger people. So I think my top tip would be, again, try and persuade older people to have talking therapies if they present with depression, because they're much more likely to do well.
Great. And then younger patients, of course, first line as well, psychological interventions and talking therapies where possible too.
Absolutely. And that's in line with NICE guidelines, isn't it?
Yeah, absolutely.
I don't know about you, Kevin. I've kind of developed a bit of a rule of thumb that particularly for younger people, if they come along saying, I feel really down, I don't know why I do, everything is going well, and then you ask them and they say, well, yes, my father had severe anxiety, my mother had OCD or depression. That pushes me more towards it being a biological explanation and maybe more in favour of using drug therapy first. Whereas people who are depressed or down because of circumstances, they tend not to respond well to medication. And they're absolutely the people who should be encouraged to have talking therapies. Is that something you've experienced?
Absolutely, very much with you. It's a very useful rule of thumb, isn't it? And for that latter group of people you mentioned, I definitely signpost to various online. I'm sure we've all got plenty of good local online resources. But CBT self-help material, for example, I find can be very helpful for those individuals, as you said, with situational symptoms. So then that segues quite nicely then with pharmacological therapy. So for those individuals then, particularly focusing again with my patients living with diabetes, whom you suspect a more biological underlying etiology and you want to consider early pharmacological therapy, any tips on what drugs we might use or certainly what drugs we should avoid to treat depression in the context of diabetes?
Yes, so absolutely. So I think we would certainly be keen to avoid anything that's sedating, and we don't really use tricyclics now. And as an aside, if people are still using amitriptyline for back pain or poor sleep, please don't. It's got a huge anticholinergic burden, makes us more likely to develop dementia, as well as making memory problems worse if we've got them. But amongst the SSRIs, we know that some are more sedating than others. So mirtazapine and paroxetine tend to be sedating, so I would avoid those. Mirtazapine, interestingly, Kevin, and I'm sure you know this, it's actually more sedating at lower dosage.
Yes,
which
is a
really
curiosity of the drug, isn't
counterintuitive, isn't it? So it's worth remembering that. It's something that I didn't realise until fairly recently. So to try and avoid those. And of course, people with diabetes are more likely to have heart disease. So you need to be a little bit more cautious about the drugs that prolong the QT interval. And I'm sure you can jump in on that and give us a list.
Yeah, absolutely. To be honest, increasingly my go-to drug if I'm managing diabetes and depression, coexisting diabetes, is sertraline. And that again, is consistent with NICE guidance. Sertraline, generally, it's been around for many, many years, hasn't it, Peter? And it's generally well tolerated, I've found from my own clinical experience, has fewer drug-drug interactions than perhaps other SSRIs. And again, relevant to what you've just pointed out, is it has least impact on the QT interval as well. So often sertraline is my go-to therapy. And actually, interestingly, we have some previous evidence, albeit a lower quality systematic review published way back in 2010, suggested that sertraline may actually be more helpful in terms of least impact on glycemic control as well, in the context specifically of diabetes. So I just start 50 milligrams once a day, and quite early on, to be honest, step up to that 100 milligram dose, even by 4 weeks, and then usually just stay on that and then titrate things depending on the situation. That's my usual sort of protocol, if you like. And often, of course, for my patients with diabetes, we do need to consider generally longer-term treatment, 6 to 12 months, really to minimize the risk of relapse in the context of a chronic condition such as diabetes. And sometimes patients may even require treatment for up to 2 years. And as always, involve our local mental health colleagues as appropriate.
Absolutely, I'd agree with that. And I think the only things I'd add is that in older people, the motto, start low and go slow, is worthwhile. Yes. So in that group, you probably wouldn't titrate it up quite as quickly. But again, it's recommended as the first line for older people. And then maybe the other thing about SSRIs that's become evident recently is that you probably do need to taper them off quite gradually, especially if you've been on them for a long time. And this is something that a few years ago wasn't really recognised, was it? But we now know that they do need to be tapered off gradually in most cases.
So, Peter, the time has flown by, actually. We've only got a few minutes left, but I thought it might be nice just to finish off with a couple of minutes discussion on this sort of emerging concept, or certainly something that's had a lot of attention recently, of diabetes distress. This is something I found really interesting and, again, very important and relevant for us all working in primary care. So diabetes distress is defined broadly as the concerns and worries about diabetes and its management. So whilst depression is a DSM-defined disorder with specific symptoms, diabetes distress reflects an emotional response, an appropriate emotional response to a chronic illness such as diabetes. So indeed, you can get distress in anybody living with any chronic condition. So what's your take on this, Peter?
Absolutely. And again, it's something that talking therapies, cognitive behavioral therapy in particular, is really helpful with, because a lot of us are living with conditions, and it's the way we approach those that makes the difference to our quality of life. So CBT may not get rid of our diabetes, but they may help us cope with it in a more positive way and not affect our life. Is that something you found helpful, Kevin?
Yeah, absolutely. I mean, I think for me, the first challenge is identifying diabetes distress. So possible signs are, if your patients, if you're sensing a feeling of they're being overwhelmed and defeated by their diabetes, or anger, frustration, negative feelings about their diabetes, or the feeling that diabetes is controlling their lives rather than them controlling their diabetes. If you're getting these sort of feelings or statements from your patients, absolutely, we should be aware of the possibility of diabetes distress. And then, as you said, very much how we manage this is support. Talking therapies, as you said, referral to psychological services, maybe referral to for an update for structured diabetes education. And then, of course, simply doing what we do well in primary care, showing empathy, reassuring and supporting that individual. So I just wanted to highlight that very quickly. It's perhaps something that is perhaps under-recognized in primary care.
I think really important. And I'd add to that the importance of other ways to help ourselves apart from formal talking therapies. I'd sometimes like to under-medicalise rather than over-medicalise. So
Sure.
we've got huge evidence, haven't we? A real evidence base that exercise is incredibly helpful. Being out in nature is incredibly helpful. Trying to keep ourselves in the moment is incredibly helpful. And this can be taught with talking therapies. But I'm as you may know, a black belt in karate. And you really got to stay in the moment there. Otherwise, you get punched in the nose. So that sort of practical lifestyle advice can make a huge difference to our patients, I think.
Absolutely. I fully agree with your comments there. So I think, Peter, unfortunately, that's time up for us. I really enjoyed that discussion with you. Thanks so much for your input there. Any parting comments for our listeners today?
I hope we've given them enough of a taster that they'll come back in May. But thank you, Kevin. I absolutely fascinating to me. And although lockdown has forced these things on us rather than the real conferences, it's actually been a huge opportunity, I think, to stress the way the different chronic conditions overlap and that we're not working in silos. There's a huge interplay between the different conditions. So thank you very much.
No problem. Thanks for joining me, Peter. And thank you all for listening. We hope you found this podcast helpful. Please make sure to register both for our other podcasts in the series and also for our interactive webcast brought to you as part of Chronic Conditions Month 2021. And you can sign up at chronicconditions.co.uk. So thanks for listening, everyone. And we hope to see you again soon.
See you in May. Thank you.